This is a very important topic uh, on electrolytes and the electrolyte imbalance, particularly related to sodium, potassium. And this will be presented by our resident Dr. Sarvesh and be moderated by our faculty, Dr. R.D. Sahu. So I would request Dr. Sarvesh to kindly share his presentation. Yeah.
Good morning, sir. Good morning, colleagues and juniors. My presentation on electrolyte imbalance, hypo-hypernatremia, hypo or hyperkalemia. Introduction. Electrolyte imbalance occurs when there is irregularity in the level of essential minerals like sodium, potassium, calcium, and magnesium in the body. These electrolytes are critical for various bodily functions, including nerve conduction, muscle contraction, and maintaining the proper hydration. Imbalance can stem from the dehydration, certain medications, kidney disorders, or hormonal imbalance, potentially leading to symptoms ranging from mild to severe, impacting overall health and organ function. Relative concentration of ratio of ions in extracellular and intracellular fluids. Sodium is mainly on extracellular ions and potassium is mainly intracellular ions. Sodium. Bulk cation of extracellular fluid. Change in serum sodium reflect the change in total body sodium. Principal active solute for maintenance of intravascular and interstitial volume. Absorption mainly through the GI systems via active sodium potassium ATPase systems. Excretions via urine, sweats, and feces. Kidney are the principal regulator for the sodium. Two-thirds of the filtered sodium is reabsorbed by the proximal convoluted tubules, increase with concentration of extracellular fluids. Less than 1% of filtered sodium is normally treated, but can vary up to the 10% if necessary. Countercurrent system at the loop of Henle is responsible for the sodium and water balance, active transport with chloride. Aldosterone stimulates the further sodium reabsorption at the distal convoluted tubule and collecting ducts. Serum sodium normal value is 135 to 145 milliequivalent per liter. Major component of serum osmolarity. Serum osmolarity is equal to 2 into sodium ion plus burn urine nitrogen divided by 2.8 plus glucose level in milligram per deciliter divided by 18. Normal sodium osmolarity is 285 to 295. Alteration in serum sodium reflect the abnormal water regulation. Hyponatremia, when serum sodium level is less than 135 milliequivalent per liter, is presented with the symptoms of anorexia, headache, nausea, emesis, impaired response to verbal and pain stimuli, bizarre behavior, hallucinations, respiratory insufficiency, decorticate and desaturate posturation, coma, and respiratory arrest. Pseudo-hyponatremia. High concentration of intravascular protein and lipid may falsely result in laboratory hyponatremia. This occurs with hyperglycemia, hyperproteinemia, uremia, and hypertriglycemia. This must be considered before correcting hyponatremia. Apply the following correction for pseudo-hyponatremia. Every 100 milligram per deciliter glucose decrease serum sodium by 1.6 milliequivalent per liter. Every 25 milligram deciliter increase the blood urine nitrogen above the normal value. Above the normal value of 25 milligram deciliter decreases sodium by 3.3 milliequivalent per liter. Before initiating the sodium correction, calculate the total sodium deficit by the following formula. Total sodium deficit is equal to body weight into 0.6 into expected sodium minus measured sodium. Hyponatremia correction should not rise by 10 to 12 millimole per 24 hours because rapid correction can cause seizures or central pontine myelinosis. So while calculating sodium deficit correction for the day, expected sodium minus measured sodium should be taken less than 10 or 12 is equal to 10 or 12 milliequivalent per liter. Note, when hyponatremia is documented to have occurred within 12 to 24 hours, it is safe to correct a faster rate. Indication for 3% NaCl intravenous correction in the patient with euvolumic or dilution hyponatremia is presented with seizure, low sensorium, very low serum sodium, less than 120 milliequivalent per liter. And 1000 ml of normal saline contains 154 milliequivalent of sodium. and 100 ml of 3% NaCl contains 51.2 milliequivalent of sodium. Evaluation with volume, serum sodium, osmolarity, blood urine nitrogen, creatinine, urine sodium, osmolarity. True hyponatremia. First is hypovolemic hyponatremia, when both water and sodium decreases, but sodium decreases more than water. It is mainly due to renal loss or extra-renal loss. Renal loss mainly due to diuretics excess, osmotic diuresis, salt wasting nephropathy, adrenal insufficiency, proximal RTA, metabolic alkalosis, pseudo-hypoaldosteronism result in urine sodium concentration greater than 20 milliequivalent per liter. Extrarenal loss may be mainly due to vomiting, diarrhea, sweat, and third space resulting in urine sodium concentration less than 20 milliequivalent per liter. Treatment by volume resuscitation with NS. Normovolemic hyponatremia. When water increase and serum sodium are stable. When hyponatremia is caused by syndrome of inappropriate antidiuretic hormone, reset osmostat, glucocorticoid deficiency, hypothyroidism, or water intoxication. Urine sodium concentration is greater than 20 milliequivalent per liter. Is treated by fluid resuscitation and correct endocrine abnormality. Hypervolemic hyponatremia. When water and sodium increase, but water increase more than serum sodium. If hyponatremia is caused by an edema forming state like a congestive heart failure, cirrhosis, nephrotic syndrome, urine sodium concentration is less than 20 milliequivalent per liter. If hyponatremia is caused by acute or chronic renal failure, urine
क्लासेस का पूछ रहा था अपनी क्लासेस ये तो
Nileshi, please stop this disturbance. Those who are, please close your mic, please. Those who are listening to it, please close.
If hyponatremia is caused by the acute or chronic renal failure, urine sodium concentration is greater than 40 milliequivalent per liter. Is corrected by underlying state. Assessment finding for hyponatremia is neurological findings: generalized skeletal muscle weakness, headache, and personality changes. Respiratory system, shallow respiration. Cardiovascular system, cardiac changes depend on the fluid volume. GI system, increased GI motility, nausea, diarrhea. Genitourinary symptoms with increased urine output. Intervention: restore sodium level to normal and prevent further decrease in serum sodium. Drug therapy: if fluid volume deficit, IV therapy to restore both fluid and sodium. If severe, maybe CV 3% saline. Fluid volume excess is administered osmotic diuretic like mannitol to exceed the water rather than the sodium. Increase oral sodium intake and restrict the oral fluid intake. Acute hyponatremia. Acute hyponatremia is when serum sodium is less than 120 and duration is less than 48 hours. Etiology present with post-operative exercise with hypotonic fluid replacement and drug-like ecstasy. Treated aggressively using 3% saline to raise the serum sodium by 5 milliequivalent per liter in 1 hour. Be aware, a rapid drop in vasopressin level. Hyponatremia when serum sodium level more than 145 milliequivalent per liter. Plasma serum sodium is more than due to increased sodium or decreased water intake. Water moves from ICF to ECF, cell dehydrate. Due to excess sodium intake, hypertonic IV solution, excess sodium retention, over secretion of aldosterone, loss of pure water is due to long-term sweating with chronic fever, respiratory infection, and diabetes presented to polyuria. Insufficient intake of water, hypodipsia. Contributing factor for hypernatremia is hyperaldosteronism, renal failure, corticosteroid intake, increase in oral sodium intake, sodium-containing IV fluids, decreased urine output with increased urine concentration. Assessment finding for hypernatremia is neurological findings: spontaneous muscle twitching, irregular contraction, skeletal muscle weakness, diminished deep tendon reflexes. In respiratory system, pulmonary edema. Cardiovascular system presented with diminished cardiac output, heart rate, BP depends on the vascular volume. Urinary system presented with decreased urine output, increased specific gravity. Skin dry, flaky skin, edema related to fluid volume changes. Evaluation with volume, serum sodium osmolarity, blood urine nitrogen, creatinine, urine sodium, and urine osmolarity. Intervention, drug therapy, fluid volume deficit. If fluid volume deficit 0.45% NS, if caused by both sodium and fluid loss, will administer NaCl. If inadequate renal excretion of sodium, will administer the diuretics. Diet therapy, mild ensure water intake. Potassium. Potassium, normal range of potassium is 3.5 to 5 milliequivalent per liter, largely contain intracellular volume. Serum sodium does not reflect the total body potassium. Serum potassium does not reflect the total body potassium. Important role is the contractility of muscle cells, electric responsiveness. Principal regulator of potassium is kidney. Daily requirement of potassium is 1 to 2 milliequivalent per kg. Complete absorption through the upper GI tract. Kidney regulate the balance by 10 to 15%. Filtered is excreted. Aldosterone increase sodium and decrease sodium excretion. Mineralocorticoid and glucocorticoid increase the potassium and decrease sodium excretion in stool. Acidosis. Low pH shift to potassium out in the cell. High pH shift to potassium into the cell. 0.3 to 1.3 milliequivalent per liter potassium changes the 0.1 unit change in pH in the opposite direction. Hypokalemia, when serum potassium level is less than 3.5 milliequivalent per liter. Behavior if diabetic, because insulin pushes the potassium into the cells. In ketoacidosis state, HIN replaces the potassium which is lost in urine. And other state, beta-adrenergic drug or epinephrine. Pathophysiology, decrease in potassium cause a decreased excitability of cell. Therefore, cell are less responsive to the normal stimuli. Causes due to decreased intake of potassium, increased potassium loss like a chronic diuretic state, severe vomiting, diarrhea, acid-base balance, trauma, stress, increased aldosterone, redistribution between ICF and ECF. In potassium deficit level, ankylosing state presented with shallow respiration, irritability, confusion, weakness, arrhythmia, lethargic state, thready pulse, and decreased intestinal motility. Amount of potassium needed. The relationship between total body potassium and serum potassium is not linear. At the lower level of measured potassium, much more potassium is required to increase the serum level by 1 milliequivalent per liter than the higher level. If sodium potassium level is more than 3 milliequivalent per liter, 100 to 200 milliequivalent is required to increase by 1 milliequivalent per liter. If serum potassium level is less than 3 milliequivalent per liter, potassium required for 200 to 400 milliequivalent is required for increase it by 1 milliequivalent per liter. 1 gram of intravenous KCl contains 13 milliequivalent of potassium and 5 ml of oral KCl contains 4 milliequivalent of potassium. Hypokalemia presented with EC changes, T wave inversion followed by QT prolongation, U wave and mild ST changes. Management mainly potassium replacement through the peripheral lines cause painful thrombophlebitis. Hence, use only 500 ml with up to the 3 gram KCl in or 1 liter up to the 4 gram KCl of normal saline as a diluent. Administration through the central line can be given in the 100 gram of fluid up to the 3 gram per 100 ml. Infusion rate should not exceeded by the 1.5 gram per hour is equal to 20 milliequivalent of KCl. Patient tolerating orally can be given syrup KCl 20 ml stat and repeated dose after 2 hours. In addition to the intravenous correction in case of severe hypokalemia. Hypomagnesemia often coexists with the severe hypokalemia. Add magnesium to the infusate containing KCl 2 to 4 gram of magnesium sulfate. Always add magnesium sulfate 2 to 4 gram to the potassium correction for severe hypokalemia when potassium less than 3 milliequivalent per liter. Patient on long-term diuretics therapy can have hypokalemia and this may be precipitate or aggravate digoxin subtoxicity. Correct hypokalemia aggressively in the patient on digoxin therapy. After correction, if patient is stable to be discharged, advised patient to continue syrup KCl at a dose of at least 20 ml BD till next OPD review. Hyperkalemia, when serum potassium level is more than 5.5 milliequivalent per liter. Check for renal disease, massive cellular trauma, insulin deficiency, Addison disease, potassium sparing diuretics, decreased blood pH, exercise pushes potassium out of the cell. Its pathophysiology by increasing potassium cause increased excitability of cells. Contributing factor increase in sodium intake, renal failure, potassium sparing diuretics shift out potassium out of the cell. Hyperkalemia present with muscle cramps, weakness, and then paralysis. Drowsiness, decreased BP, ECG changes, dysarrhythmias, abdominal cramps, diarrhea, and olguria. ECG changes with hyperkalemia is peaked T wave, broad QRS, ST depression, and sine wave pattern. Treatment of hyperkalemia. The when goal is cardioprotective effect, 10 ml of 10% of calcium gluconate over 4 minutes. For intracellular shift, salbutamol nebulization 5 milligram every 15 minutes for three doses given. 50 ml of 50% dextrose with 8 unit of short-acting insulin over 10 minutes. If RBS is high, give only insulin. Eliminate from the body. Furosemide 40 to 80 milligram IV stat and repeated after 4 hours if blood pressure is normal. And also use potassium binding resin syrup 30 gram of caxylate syrup with 12.5 gram mannitol in 100 ml of water. Hemodialysis also do with treatment in hyperkalemia. Calcium, normal range of calcium is 8.8 to 10.1 milligram per deciliter with half pound to albumin. Enhanced calcium is half of the active is equal to 4.4 to 5.4 milligram per deciliter. Majority is stored in bone. Hypoalbuminemia is falsely decrease the calcium. Calcium corrected value of calcium is equal to calcium measures plus 0.8 into albumin normal and minus albumin measured. Assessment finding of for calcium. In neurological finding, irritable muscle twitching, positive Troisier sign, positive Chiwetzko sign, respiratory system is present with respiratory failure due to muscle tetany, cardiovascular system decreased heart rate, decreased BP, diminished peripheral pulses, GI system presented with increased mortality and increased bowel sound, diarrhea. Positive Troisier sign. Positive Troisier sign, induction of carpopedal spasm by the inflation of sphygmomanometer above the systolic blood pressure for 3 minutes. Positive Chiwetzko sign. Positive contraction of ipsilateral facial muscles elicited by the ipsilateral tapping of ipsilateral facial nerve is anterior to ear. Hypercalcemia, when serum calcium level is more than 10.5 milligram per deciliter, is contributing factor is excessive calcium intake, excessive vitamin D intake, renal failure, hyperparathyroidism, malignancy, and hyperthyroidism. Is intervention is for treatment, eliminate the calcium administration, drug therapy, isotonic NaCl, which increases the excretion of calcium, diuretics, calcium reabsorption inhibitor like phosphorus, cardiac monitoring. Magnesium normal is in 1.5 to 2.3 milligram per deciliter, 60% is stored in bone, 1% in extracellular space, necessary cofactor for many coenzymes. Renal excretion is primary regulation. Hypomagnesemia, when serum magnesium less than 1.4 milligram per deciliter, contributing factor is malnutrition, starvation, diuretics, aminoglycoside, antibiotics, hyperglycemia, and insulin administration. Assessment finding for neurological system, positive Troisier sign and positive Troisier sign also find in magnesium deficiency, hyperreflexia, seizures. In cardiovascular, ECG changes, dysarrhythmias, hypertension. In respiratory system, shallow respiration. In GI system, decreased mortality, anorexia, and nausea. Intervention through eliminate the contributing drugs, IV magnesium sulfate, assessment deep tendon reflexes hourly with magnesium sulfate, and diet therapy. Hypermagnesemia is hypermagnesium with serum magnesium is more than 4.8 milligram per deciliter, is contributing factor with increased magnesium intake, decreased renal excretion. Assessment finding for neurological system, reduce or weak DTR, weak voluntary muscle contraction, drowsy to the point of lethargy. In cardiovascular system, bradycardia, peripheral vasodilation, hypotension, and ECG changes. Intervention with eliminate the contributing drug, administration diuretics, calcium gluconate, reverse the cardiac effect, and diet restriction.
So thank you, Sarvesh, for the presentation. I once again welcome all the listeners and the audience here our very senior urologist, Dr. A.L. Bhatt, is with us, and the other faculty members, Dr. Nachiket and everybody. Once again, a very, very happy New Year 2024 to all of you. I think this is a very important chapter. The last time we discussed about acid-base balance, and this time the electrolytes imbalance. We often neglect this chapter, and I think if you are aware of how to manage electrolyte imbalance and acid base, you actually can help the patients, very critically ill patients. And it's maybe life-saving at times also. So it's really amazing to see how the body functions. The pH of the body, which is around 7.4, how it is maintained, the homeostasis is maintained by the acid-base balance is really amazing. Similarly, electrolytes, we know there are electrolytes in the body. There are some which are intracellular, some extracellular, cations and anions, mainly the sodium, potassium, calcium, magnesium, the cations and anions, bicarbonate, chloride, phosphates, sulfates, etc. So how they maintain the homeostasis, and this sodium, potassium, and the electrolyte balance helps to maintain the electrical neutrality of the cell, which is vital for functioning of life. And how this helps in the function of the muscles, the cardiac muscles, the skeletal muscles, the nerve impulses, and how this actually generates the action potential, which is responsible for the function of these tissues. The sodium potassium ATPase pump, which acts over the cellular membrane, we know is probably the most important mechanism where the sodium potassium goes inside the cells and sodium by active transport, and that maintains the homeostasis. And sodium ion, which is an extracellular cation, helps to maintain the extracellular fluid volume. And so we all have understood how the different problems, disorders can cause a different dyselectrolytemia, hypo, hyper. And so basically, we all know that the sodium is mainly controlled by hormones in the kidney, which is aldosterone, where the sodium gets reabsorbed and the potassium actively secreted. So all this, and then we have drugs. There are various drugs we also must understand which can cause dyselectrolytemia. There are antibiotics, diuretics, antihypertensives, and so many other drugs which can cause this imbalance. He talked about magnesium. Magnesium, we often neglect the magnesium ion, but magnesium is again is a very important ion for the maintenance of the ATPase pump, for generation of the neurotransmitters, etc. And we all know if it goes less than 1.46, there may be problems. Even drugs like omeprazole, which we give so often, and they are being taken chronically, they can reduce magnesium level to a very low level, can cause hypomagnesemia. So I think all these are very interesting to know and very important to know when we treat these patients. So thank you all. If any of the resident and faculty has any question or anything you want to add, please, you are most welcome. And in the meantime, I would request Dr. Bhatt also to just come, because it's an honor to have him with us today in the new year 2024. Welcome, sir. And if anybody else has anything to say, you can put it in the chat box, or you can just put your thumbs up and we will demute you. Please, Dr. Bhatt, please.
Thank you, Dr. Shivam, and the faculty and the Department of Urology for giving me this opportunity to say a few words. let me take this opportunity to say Happy New Year to all of the attendees as well as the online listeners. The electrolyte imbalance is very, very important. I'll tell you two of the incidences which I have come across at SP Medical College, Bikaner. I was being called as a consultation reference. The patient is in anuria, a very VVIP, superintendent's mother, and she is not passing urine since last 2 days, hardly 1500 ml. I went there, I saw all physician treating. I simply told them she is in hyponatremia, given normal saline. So there was a naturally treating physician. How can we give normal saline this month? I told them that just you give at least 250 and see for half an hour. And to all these residents, I can tell you, just after they went on giving the diuretic, but there is no sodium. How can there be water? By simple giving NS, she started passing water, and there was no other pathology in that. Similarly, I got one call for this one. Patient is drowsy. We don't find anything. Told them get magnesium. Done. Replace that. That will good. So these are few clinical incidences. And what is electrolyte imbalance is the most important first chapter to any clinician, and especially among the urologist is very important because you will get many time such calls. With this, I think he has covered all part, and I congratulate the department for having such sessions. Thank you.
So thank you. I would again request my residents and those residents who are listening to us, please be interactive and give your kind of feedback, queries, suggestions. In the meantime, I would request Professor Nachiket Vyas to give his comments, please.
Thank you, Shivam sir, and thank you, Bhat sir, for coming to the class. And it's always an honor having such a great person with us. And I take this opportunity to wish everyone a wonderful 2024. And I think that we've started 2024 academically with a very important topic about electrolyte imbalance. And I think that electrolyte imbalance and the role of ions for the management of the internal milieu of the body can be understood by the fact that now in Harrison's there is a whole segment which is on channelopathies, and there are so many now. The overall basis of multiple disease process inside the body has been classified as problems of channelopathy. So whenever we are discussing about electrolyte imbalance, then basically it is a problem of the channelopathies of the cell. As Sir said, it's important to maintain the neutrality of the cell, and they play a very complex role inside ultimately maintaining hemostasis and maintaining the milieu of the body. As far as urology goes, now there is a new drug which is being studied for overactive bladder, and that is chromocalcium. Chromocalcium is again a channel blocker, a potassium channel blocker, and hyperpolarization of the mucosa of the detrusor muscle might be also another. It will open the research into a whole array of a new variety of drugs. So I think that maybe we can also have another session on channelopathies and new drugs which are inside the foray for urological diseases. And thank you. I think that he covered the seminar very well. And thank you everyone for attending. And please do continue to support Department of Urology in all these academic and non-academic activities that we have. Thank you very much.
Thank you, Nachiket. I think a very important and pertinent comment made. You should remember from when we are treating elderly patients, as Dr. Bhatt said, these things are very common, and particularly they have already certain comorbidities like diabetes, like chronic kidney disease, and etc., where they are prone to get this imbalance electrolytes. And then if you add drugs like diuretics, antibiotics, and other drugs, there are so many drugs which can produce this imbalance also. So it is very important to understand how this works and how it can affect the body. Like a thing called Bartter syndrome. If you have heard, it's a congenital disorder where it is a hypokalemic metabolic alkalosis. So if you do not know exactly what it is, you may not. And there is something called antibiotic or drug-induced Bartter syndrome. So there are certain antibiotics like aminoglycosides and other antibiotics which can produce this kind of syndrome and produce hypokalemic metabolic alkalosis. So it's very important and very interesting. If you try to get into it, the subject, you find it really interesting. Because how the body works, it's really amazing to know. And ek cell, how it works, and how this iron balance is maintained by the simple sodium potassium ATPase pump, and it maintains the electrical neutrality of the cells, without which the life cannot function at all. So it's very interesting. So thank you once again. I would request Dr. Adi, our moderator today, to kindly give his concluding remarks, please. And anybody, any of the residents? No? Okay.
Thank you, Bhatt sir and Shivam sir, for enlightening us this important chapter. Thank you. Thank you all.
And Happy New Year.
Happy New Year to all.
Okay. Thank you, Adi. Thank you. Thank you very much. So I once again wish all my residents, my faculty members, sir, who has spared his valuable time to come in our class today, and all the listeners on our Zoom and YouTube. And Nimeshji, we have taught already. So Nimeshji, I wish you also, and I actually thank you for helping us to conduct our classes too. Thank you very much.
Thank you very much.
Happy New Year to all of you. Thank you. Have a good day.